Doktor, kita boleh mula, Doktor? Doktor mute.
Hi, Assalamualaikum and good morning to everyone. I'm Dr. Majmin from Pediatric Surgery. Today is our turn to do the CPC together with our radiology colleagues, oncology, and also pathology colleagues. So our presenters for today's are going to be started with Dr. Saleha Takin, which is our master's student in pediatric surgery, and then followed by Dr. Erica Yihing, which is a pediatric radiologist here. Then with Miss Azrina Zaman, who is our specialist in pediatric surgery, followed by pathologist, which is Dr. Shaziani, and also Dr. Aziani Yahya. Then to end the topic today, Dr. Lo Sikai from Pediatric Oncologist will give a talk on the oncological part. The panelists for today will be myself and Dr. Lo Sikai, Prof. Tan Giok Chin from pathology, and Dr. Erica from radiology. I think without further ado, we are going to start presenting on the Mass'Ive Conundrum, which you will understand later why. Dr. Saleha?
Okay, thank you very much, Ms. Majmin. Okay, I hope everybody can see my slide. Is it okay?
Yes, Saleha.
All right, okay, thank you. Assalamualaikum warahmatullahi and a very good morning I bid to all. I am Dr. Saleha, pediatric surgery trainee from Department of Surgery, HCTM. Our CPC topic today is a very interesting one, and I will present the case summary. Okay. Why I cannot, sorry. Pause share. Okay, all right. This is an 11-year-old boy. He presented with abdominal pain for 1 week duration at left hypochondrium and also abdominal mass for 5 days. He had no other complaint, no change in bowel habit, no constitutional symptom, as he had no weight loss, he had good appetite and no fever. He was treated for constipation at the private hospital but came to HUKM as no resolution of symptom. Birth history, antenatally uneventful. He was born full term with birth weight 2.6 kilogram. There is no past medical and past surgical history. For the family history, it was non-consanguineous parents, but he had positive family history of malignancy where the grandmother had breast cancer. Diet history, he eat normal adult diet but disliked vegetable and immunization was complete. Physical examination, the general examination, he was alert, grossly normal child, not syndromic, good hydration, good perfusion and not tachypneic, but noted the blood pressure was more than 95th centile where the systolic range 118 to 124 and diastolic range 72 to 76 millimeter mercury. Otherwise, lungs and CVS examination was unremarkable. Per abdomen soft, firm to hard left subcostal mass extending about 9 cm below the subcostal margin and unable to get above. For the blood investigation, routine blood investigation were unremarkable, but the additional investigation, LDH raised, which is 516, and 24 hours urine catecholamine also shows significantly raised at 17,000 nanomole in 24 hours. Further investigation, the boy underwent CT abdomen, noted there is large, well-defined heterogeneous mass, measured about 14 times 9.3 centimeter in the left side of the abdomen. However, the mass is uncertain origin as features non-specific and differential diagnosis at this point is rhabdomyosarcoma and neuroblastoma. Then the boy underwent ultrasound guided biopsy. The HPE shows small round cell tumor and differential diagnosis were Ewing sarcoma and neuroblastoma. There is no evidence of EWSR1 gene rearrangement to suggest Ewing sarcoma. However, we're still unable to differentiate between Ewing sarcoma and neuroblastoma in view of unavailable staining for further testing, which is the FLI1 immunohistochemistry staining. So as for management, it was inconclusive tumor type from HPE. Discussion at MDT with oncology were made. Due to uncertainty, we are unable to start new adjuvant chemotherapy and he underwent laparotomy with tumor excision and chemopod insertion. And then the tumor HPE came back suggestive of neuroblastoma, Schwannian stroma poor, which is poorly differentiated. And the final diagnosis was neuroblastoma. Today, we would like to discuss in detail about this topic. Thank you.
All right. Thank you, Saleha. So I will be taking over for the imaging part. Let me share my screen first. Hold on. Can I check that we are looking at my slides? So I'm Dr. Erica. Good morning to everyone. So I'll be talking about radiological part of this patient. So the first imaging that we had with this patient is actually a contrast enhanced CT abdomen, and it was done outside actually because he was referred from somewhere else. So it was 2 days before admission. Just let us go through a very brief account about the anatomy, okay, because it will help us understand why we conclude the CT scan that way. So we have a schematic picture drawing showing the retroperitoneal structures. This is the parietal peritoneum. This is the pancreas. So everything behind the parietal peritoneum is retroperitoneum. Okay, so this is the pancreas here in the anterior-most retroperitoneal space, which is called the anterior pararenal space. The descending colon is in the same space on the left side, and the ascending colon on the right side. Then behind in the middle is the inferior vena cava and the abdominal aorta, and the kidneys are in their respective perinephric spaces. So the entire thing here is retroperitoneum, okay? Yeah. So with the understanding with this, then now we will be looking at the patient's CT scan. And over here, we see a very large heterogeneous mass with multiple stippled or mottled calcification within. Sometimes we call it amorphous because it is quite irregular, some big, some small. And there are areas of hypodensity where it is suggestive of fluid, okay, it's cystic component. And over here, this is the spleen. Okay, spleen is an intraperitoneal structure. Usually it is situated somewhere here, but in this case, because of the mass, it has been pushed forward. And this is the pancreas over here. So remember the schematic drawing just now. Pancreas is a retroperitoneal structure which is situated most anterior. So it has been displaced forward. Usually it lies somewhere here. It has been displaced forward by the mass. So because pancreas by itself is retroperitoneal, so a mass that pushes it forward definitely will be arising from retroperitoneum. Okay, so in that case, we can conclude that this mass arises from the retroperitoneum space. And this small structure here, we were unable to ascertain whether it is the left adrenal gland or the some vessels, okay, because of the small structures and they are all crowded together. And the normal right adrenal gland is over here. If you can see this very fine tubular thing within the black area, which is the fat, okay. So this is the liver, and this thin layer here, thin soft tissue here is actually the normal right adrenal gland. So the left adrenal gland we were unable to identify in this patient. And in this scan also, we were able to tell the margin of the mass from all the surrounding structures where this is the crust of the diaphragm where we don't think there is any infiltration into the surrounding structures, okay? The abdominal wall also looks quite clear. There's no abnormal enhancement. In the next slide, oh, sorry, just go back a bit more. At this part where the mass actually abuts the vertebra, we don't see any extension into the neural foramina. So there is no intraspinal extension. Further down, this is axial, further down where we see the mass again and more necrotic cystic component, which most likely represents necrosis, and a lot more calcifications and enhancement, solid component. And here we start to see the upper pole of the of the left kidney, okay? So look at the location of the right kidney in its normal. This is the normal location. So left kidney should be situated somewhere here if it is not displaced. In this case, we see the kidney being displaced anteriorly and medially, okay? From here, it is lateral, it goes medial, and it goes anterior. So again, kidney is a retroperitoneal structure which is situated posteriorly, if you remember the schematic drawing. So it also tells us that this mass actually arises probably from behind the kidney, and that's why the kidney is displaced forward and medially. And in this slides also, we were able to identify a hypodense lesion, which is between the kidney and the aorta. This is the abdominal aorta here. So this lesion here, in the CT scan, we were initially unable to ascertain whether this is a lymph node, a para-aortic lymph node, or the left adrenal gland, which is also displaced. So we were a bit unsure about that in the beginning, and we will see what we can do about it. Again, this mass shows a very well-defined margin, which does not seem to infiltrate any structures around it. And this is lower, even lower down, where we see the kidney better at the hilum region. This is the PC, the pelvic calyceal system, the renal pelvis, and the ureter coming out with contrast inside, because this is a delayed phase. Okay, and the mass again with a large cystic necrotic component. And this is the psoas, left psoas muscle over here, which also is a bit flattened, but it does not seem to be infiltrated because there is no abnormal enhancement. So based on this, there's another image here. This is a reconstructed coronal scan from the previous CT scan that I've shown you. So it can be reconstructed into a coronal image like this. And this shows us the full extent of the mass, which is like 15, 16 cm in this longitudinal length. So you can see that it abuts the diaphragm on the left side, and it goes down to the iliac crest region. So it's at almost at the pelvic inlet area. So it's very big. It occupies almost the entire left lumbar region. Okay, and this is the IVC here. This is the left psoas. So this mass did not show any evidence of vascular or any solid organ invasion in this case. And it looks like it is just a very well-defined lesion on its own. Although in this case we couldn't ascertain from what organ it arises from, but we can be sure that it is a left retroperitoneal mass. So on admission over here, in order to confirm the para-aortic node or adrenal gland that we saw on the CT scan, we did an ultrasound. So over here, this is the mass. Okay, this is the mass which looks very heterogeneous, and the hypoechoic, which is the black area, is the cystic component that we saw on CT scan, and the hyperechoic part, all these small stippled things, are the calcification actually. And with color Doppler, we can tell this lesion is quite vascular. There's quite a lot of vascularity within the tumor. And this image is trying to show the right adrenal gland, which is normal. You can see a Y shape here. This is the body limb and the medial and the lateral limbs of the right adrenal gland. This is the upper pole of the right kidney, and this is the liver. So this is the normal right adrenal gland, which is demonstrated again. And this is on the left side. This is the upper pole, the medial aspect of the left kidney. We saw this almost triangular shaped hypoechoic structure, which there was another image to show that there is vascularity supplying the middle part with some fat component within. So we thought this is most likely a para-aortic node instead of left adrenal gland. So from a combination of these two imaging, we were unable to identify the left adrenal gland with confidence. Okay, so the conclusion would be a left retroperitoneal tumor with para-aortic lymph node involvement on the left side. So the differentials that comes at the moment are by the rank of probability. So neurogenic tumor will be the most likely at the moment based on the imaging features. Okay, and the germ cell tumor comes the next, and the least likely ones are actually sarcoma or lymphoma. And let's have a brief look at each. So when we talk about neurogenic tumor, the most common in children are neuroblastomas. Okay, that's the most common one, but there are many other types of neurogenic tumor. They usually are irregular lobulated masses. So in this case, we have a quite well-defined mass, but it does have some lobulations at the margins. 70% of neuroblastoma shows signs of metastasis at diagnosis. Okay, so there is a para-aortic node that we saw on this patient. The lesion usually, the primary tumor is usually very heterogeneous because they contain necrosis and hemorrhage, and 80 to 90% of them actually calcify. And the calcification is usually described as amorphous, which means very irregular in shape and coarse, okay, which this patient can fit in. The neuroblastoma, very commonly, they show signs of invasion into adjacent organs, and they encase vessels, which these two we are not seeing in this patient. And the most common ones usually displace kidney inferior and laterally, because most of them arise from the adrenal gland. That was why we were searching very hard for a normal adrenal gland. So when a mass arises from adrenal gland, okay, adrenal gland usually sits on top of the kidney, medially to the kidney. So imagine when there is a mass arising from there, it will displace the kidney towards laterally and below it. Inferiorly. So this was contradicting our patient because we saw the kidney displaced anteriorly and medially, which is the opposite direction of the usual neuroblastoma that arise from adrenal gland. Okay, so this is a point against. And most of the neuroblastoma patients present before 10 years old. This patient is around 11 when she presented. So this is something that makes neuroblastoma slightly less common, okay? Yeah, but based on imaging features, neuroblastoma is probably still the most likely diagnosis with some atypical presentation and features. And then the next one, we talk about a germ cell tumor, and the most common one being teratoma. It is rare, so mostly it arises from ovaries or testes. In this case, of course, there was no testicular tumor, but it occurs very rarely in retroperitoneal space. Most of them are benign. They contain fat, fluid, and calcifications. And the calcifications usually are more chunky than the ones that we have here. Sometimes they can have tooth-like appearance, okay, because they are differentiated. And one point against teratoma in this patient was we didn't see any fat component in this patient. Okay, CT is able to detect fat, which is significant. But in this case, there was no fat component to be seen. And if there is presence of any invasion, hemorrhage, or necrosis, this actually suggests malignant type of teratoma. So yeah, and so teratoma is the second likely compared to neuroblastoma in this case. Sarcomas, the most common one in children is rhabdomyosarcoma. It can occur at any site. It is usually infiltrative mass, unlike what we see in this patient. It usually metastasizes to lymph node, lungs, and bone. The imaging feature, usually they are heterogeneous with necrosis, but calcification is very rare. So with so much of calcification in this patient, it makes rhabdomyosarcoma less likely, okay? And also, majority of the patients are less than 10 years old when they present. This is another point that goes against. The least likely one is lymphoma, where because very rarely they present initially with a large mass in the retroperitoneum when there are no other lymph nodes enlargement seen anywhere else. So the more common presentation is they present with a lot of lymph adenopathy, lymph node enlargement at a lot of other places, not only in the retroperitoneum. So in this case, it makes it less likely. And also because the enhancement pattern for lymphoma lesions, they are mostly homogeneous, and enhancement is very mild. So this patient is very heterogeneous, okay? And the necrosis and calcification are rare before treatment. This is also another point against, okay? So then now let's go to discuss a little bit of how each imaging helps us in the diagnosis of an abdominal mass, okay? So the main imaging that we use in the initial part are ultrasound, CT, or MRI. Okay, CT or MRI will depend on what the differential that we think based on ultrasound findings. So ultrasound is usually the initial modality for assessment of any abdominal mass in children because it is radiation-free, okay, and it is of low cost. And it is able to determine the likely origin of the mass most of the time, but not always. Okay, and it will be able to tell us the relationship of the mass with the surrounding structures. Okay, and it can show us whether the mass is vascular or not, like what I have demonstrated to you by Doppler. And sometimes if there is any vascular invasion, we are able to assess for that as well on Doppler. And an important feature of ultrasound is able to guide us during a core biopsy, okay? Guide us with the needle where we are puncturing to get the biopsy sample so that it is more representative. Contrast-enhanced CT is most commonly used in further characterization of abdominal mass after an initial assessment with ultrasound. Okay, it has the advantage of being very short. We are talking about seconds, okay, 10 to 15 seconds in modern machines. So it's a very short examination. And it is able to assess for the relationship with surrounding structures, as I have demonstrated to you earlier on, superior detection of calcification. So it is very good. It is the best modality for calcification pickup, okay? And it is sensitive for lung and solid organ metastasis, but it is not sensitive for bone metastasis. So it is not good for it. Or it can only detect it when the changes are very obvious. And the shortcoming is it imposes a very high radiation exposure to the children. So that is one point that we need to consider whether we are going to do this, whether the benefit is more than the risk. And for MRI, it has the advantage of being radiation-free. It has better soft tissue contrast than CT. It is more sensitive than CT for bone and solid organ metastasis, and also if there is intraspinal extension. So if the patient has got any neurological symptoms which is suspected to come from the spine, MRI will be the imaging modality of choice in this case and not CT. And the disadvantage of MRI is it is a very long scan. We are talking about hours, okay? It's at least half an hour to 2 hours. So deep sedation is needed for very small children. And it is worse than CT scan because it is very difficult to detect calcification on MRI. And another shortcoming is it is not sensitive for lung metastasis. So if you are looking for calcification, looking for lung mets, CT is the one that we should go for. So in general, there is significant overlap in imaging features of retroperitoneal tumors in children. And when typical imaging features are seen in typical age group with typical presentation, then the differentials can be narrowed down. But the diagnosis still relies on HPE. In this case, most of the imaging features point towards neuroblastoma, which can arise from sympathetic chain at the back, okay? But the non-typical ones are the way that it displaces the kidney and also the age group. Yeah, so there are some points that makes it not so typical. Imaging plays an important role in staging, okay, and also pre-operative planning. So this is the main role of imaging at this stage. And now let's go a little bit deeper into imaging, which is more specific for neuroblastoma. So ultrasound, CT, and MRI has been already elaborated earlier on, but I would just like to say that for staging of neuroblastoma, imaging is important in identifying we call it IDRF, the imaging defined risk factors which help to stage neuroblastoma. And that one will need either the CT or MRI to help us to tell the invasion of vessels or invasion into surrounding structures like diaphragm, and also how many compartments the tumor cells are seen. So these are the things, are the information that we can extract from CT and MRI. And the three below here, Mibg Skintography, FDG PET-CT, and bone scintigraphy, these three are all nuclear medicine studies, okay? And they have an important role in staging for neuroblastoma. And let's take a brief look at them. So Mibg Skintography is usually done in our center with SPECT-CT for anatomical information. So they are overlapped to get anatomical information on top of the functional imaging. So it is a test of choice for identification of metastasis during staging of neuroblastoma. It is taken up by norepinephrine transporters, which is found in 90% of neuroblastomas. Yeah, so 90% of the time, Mibg would show something or will be positive if it is neuroblastoma. So it also allows treatment response evaluation in disease surveillance. In this patient, we didn't do Mibg scintigraph because of the availability problem. Yeah, in our center, we don't store Mibg. So it is only ordered when it is needed. And the process of getting the order done takes quite a long time. So in the interest of time, and a technician bone scintigraphy was done in this patient instead. So bone scintigraphy is taken up by 74% of neuroblastoma. It has a lower sensitivity, but nonetheless is still applicable when Mibg is cannot be done in time. So it can detect bone metastasis when primary tumor is not Mibg avid. That means the primary tumor doesn't take up Mibg, then we can consider doing this. Or when Mibg is not readily available, like what we have in our patient. So these are the images of bone scan done in this patient. So over here, this is the anterior view of the patient, and this is the posterior view. This is just different contrast of the same they are at different phases. And so over here, we see the mass, the left retroperitoneal mass having increased uptake with some more avid foci within. And there is one spot over here along the left, overlapping the vertebra on the left side. So when they overlap the SPECT-CT, they were able to detect that this spot comes from the para-aortic node. So this bone scan demonstrates that there is no other significant abnormal uptakes in the rest of the skeleton. So there is no skeletal metastasis, no bone mets. Okay, these bright spots, which are symmetrical, are all the physiological uptake. So they are normal. They are not pathological. So this patient did not have a bone mets. And another imaging that we usually use in staging and follow-up is FDG PET-CT. So it detects metastasis when primary tumor is not Mibg avid, or when there is discrepancy in Mibg scan and the anatomic imaging, meaning you see an abnormal uptake, but anatomically we don't see any lesion, then you may consider doing a FDG PET-CT. Or when Mibg is not readily available, then we can also consider this. So in this patient, we had an FDG PET-CT done afterwards, after the surgery. Okay, after surgery, it was done for surveillance. So in this PET-CT, there was abnormal uptake at the left para-aortic region, which represents the para-aortic node that has not been removed during surgery. Yeah, so there was still residual disease, but otherwise the main large mass was gone. This is excretion within the kidneys. So these are symmetrical and physiological. They are normal ones. So only the left para-aortic uptake is abnormal. And I would like to also introduce you to MRI whole body. We have been doing this for quite some time now for imaging surveillance in solid tumor in children. Okay, it is how it differs from the conventional MRI that I have mentioned earlier is they are normally done in only coronal planes. The conventional MRI are usually done in axial planes. So they are done in coronal planes at segments, and they are fused together to show from everything from the vertex to toes. But because of time, the duration that is needed for all this, usually it is only done in one phase, one sequence, which is T2, fat saturated, or the inversion recovery sequence. Yeah, so there's only one type of sequence done to save on time. Sensitivity of MRI whole body is equivalent or more than or better than bone scan for bone metastasis. Okay, so it means that it is very sensitive. It also has higher sensitivity than MIBG. So it is better in the sense of picking up lesions. But the problem is it has low specificity. That means lesions being picked up on MRI may not actually mean that the lesions are definitely part of the tumor. It can be something else, or it may represent a lesion that is no longer active. So MIBG and PET-CT are better in determining tumor viability. This is the patient's MRI whole body that was done much later after surgery for follow-up. So over here you can see the entire body from the head until the brain until the toes, and over here we can see a little bit of this left para-aortic nodes along the vertebra. So in conclusion, ultrasound is the initial imaging of choice in abdominal mass or in neuroblastomas. CT or MRI or both of them further characterizes the mass and evaluates for imaging defined risk factors, which Dr. Loh will talk about briefly later on. Mibg Skintography is usually recommended for staging, but if it is not available, then bone scintigraphy, FDG PET, CT, and MRI whole body may be used either alone or in combination because they have different strength and weaknesses. They can be used as adjuncts for evaluation of metastasis and for disease surveillance. With that, I thank you.
Assalamualaikum. Good morning to all. I hope you can see my screen. So, my name is Dr. Azrina. I'm the specialist in pediatric surgery working here. So, I will present briefly the management of neuroblastoma from a surgical perspective. Okay, so a little bit about neuroblastoma. As Dr. Erica has already mentioned, neuroblastoma is a type of embryonal tumor of the sympathetic nervous system, and it's actually derived from the neural crest cells. It's also the most common solid extracranial malignancy of childhood. In the United States, there's roughly 1 per 100,000 cases of neuroblastoma a year. Almost 90% of cases of neuroblastoma present under the age of 5, and it's rare in patients over the age of 10. So our patient who's 11, he falls under the category of rare. Patients who present over the age of 10, the tumor usually lies within the high risk group. Okay, so I'll tell you a little bit more about risk stratification later. Okay, so in terms of investigations that we would normally perform when a patient presents with a mass that's suspicious of neuroblastoma, we will send off a urine sample for urine catecholamine. Okay, so the commonest catecholamine that we send for neuroblastoma is actually urine vanillyl mandelic acid, or urine VMA, and urine homovanillic acid. In this patient, unfortunately, at that particular time, these two tests weren't available. So what we had sent for was just urine catecholamine, looking at your adrenaline and your noradrenaline. Okay, so your noradrenaline is a precursor for your urine vanillyl mandelic acid, and in this patient, it was elevated. So the other things we would perform would be we would carry out imaging investigation, like Dr. Erica attributed to earlier. And the purpose of imaging is to look for image-defined risk factors. So what are image-defined risk factors? Broadly speaking, we're looking for evidence of invasion into other organs or structure, especially blood vessels, encasement of blood vessels, and also compression of other structures and organs. We will also organize for tissue biopsy if there are any uncertainties. And the benefit of doing a biopsy is that we can send off for immunohistochemistry stainings to try, because as Dr. Saliha had already mentioned, neuroblastoma falls under a group of tumors called small round blue cell tumors, okay? And for purpose of differentiation, you need to carry out immunohistochemistry staining. The other thing that is beneficial is you can do a FISH test to try and identify for any genetic abnormality, like Mibg amplification in neuroblastoma. So the staging that we normally carry out in neuroblastoma, we follow the International Neuroblastoma Risk Group Staging System. Okay, so this has replaced the old system, which is the INSS system. Okay, so it's divided into a localized tumor, loco-regional tumor with presence of one or more image-defined risk factors. M is when they have distant metastatic disease. Okay. And MS, now this is a special category of metastatic disease that affect children younger than 18 months of age. Okay, they generally have a better prognosis if their Mibg amplification status is normal. Okay, so why do we risk stratify patients with neuroblastoma? The reason for this is because it affects the management that we carry out to try and treat this neuroblastoma. Okay, so the patients are assigned generally into 4 overall risk groups: very low risk, intermediate, and high risk. Okay, so how do we assign this risk group? It's based on age, the INRG staging, biological tumor characteristic, including MICAN or Mibg amplification, if there are segmental chromosomal aberrations, and if there are DNA ploidy. Okay, if the biopsy or the histopathological examination comes back showing ganglioneuromas or ganglioneuroblastomas, this patient usually have better prognosis and they fall into the very low risk group. Okay, so this is what we call the INRG survival tree. Okay, so if you see, they divide it based on the categories I mentioned before. So this is the INRG staging, the L1, L2, M, and MS. The ganglioneuroma and ganglioneuroblastoma histopathological examination, they have a better prognosis. So they fall in the very low risk, which is the green. So it follows the traffic light system almost, okay, but it has 4 colors. So the green group, they have the better prognosis. Then comes the yellow group. Okay, so that's the low risk. The orange are the intermediate risk, and the red are the high risk. Okay, so they are the ones that so like K, N, O, P, Q, R are high-risk groups. So they usually based on endemic amplification, whether there's any metastases, any aberrations or chromosomal abnormality, and based on age. Okay. So when the risk stratify, it affects their treatment because of their overall survival. So if the patients fall in the very low risk group, they actually do fairly well, and their predicted 5-year survival or expected disease-free survival is more than 85%. And on the other end of the spectrum, if they fall in the high risk group, their predicted 5-year survival is actually less than 50%. Okay, so from a surgical perspective, there is a slight variation in approach of management of neuroblastoma. So first of all, I'd like to highlight that the management of any kind of tumors, it actually undergoes a multidisciplinary approach. So we have a tumor board meeting, which will usually include the oncologist, the radiologist, and the histopathologist to try and identify what is actually the best approach for management of this patient. Okay, so I mentioned that it's slightly varied. So it's varied because of different ways and different approaches from countries of in America and also from the European side. Okay, so that's Children Oncology Group. That's what COG stands for. And that's the guideline that the Americans will follow. And the CCLG group, which is the Children Cancer Leukemia Group, that is the guideline that most European nations would follow in terms of management of neuroblastoma. So from a surgeon's perspective, the kind of approach we have is either we perform upfront surgery. So this is more in keeping with sort of the American approach, where they, if the tumor does not have significant amount of image-defined risk factors, then upfront surgery or primary surgery would be best considered. And the other option is surgery following neoadjuvant chemotherapy. Now, the only difference between this is essentially timing of your surgery and the risks associated with the surgery, because usually when you perform upfront surgery, the tumors tend to be larger, okay? So it, of course, will be associated with surgical risks. Whereas surgery following neoadjuvant chemotherapy, you've given an opportunity for the chemo to try and shrink the tumor. So the risk associated with carrying out surgery is usually slightly less. However, it's balanced against timing. So when you do upfront surgery, you're doing it fairly quickly following diagnosis. Whereas if you perform chemotherapy, then there is a slight delay. And of course, chemotherapy also has impact on healing post-surgery and other surgical complications like wound infection, wound breakdown. Okay. So a little bit about COG management approach. So the first thing we always do is we carry out a receptability assessment. So you have to consider if there's any extension into adjacent structures, whether it's fixed or it's encasing major blood vessels. So in this case, we are quite lucky because as Dr. Erica mentioned, there didn't appear to be any encasement of the major blood vessels within the abdomen, which will be your aorta or your IVC. So if there were those image-defined risk factors present, the risk of hemorrhage will be higher, okay? And of course, we also have to look at the overall tumor burden to assess whether primary resection is applicable or not, okay? So always the goal of surgery is to resect or to carry out resection as complete as possible without removal or permanent damage to other structures, okay? And you can carry out primary resection if there's no significant delay to chemotherapy initiation. And this is in accordance with the COG guidelines. Okay, for tumors that are deemed unresectable, they should have an initial biopsy and central venous access placement because you need permanent or long-term central venous access placement for chemotherapy. And in high-risk neuroblastoma group, they also need central venous access for peripheral blood stem cell harvest, okay, which I'm sure Dr. Low will be discussing later on. So the goal of performing biopsy in this unresectable tumor group is to obtain enough tissue to ascertain a histopathological diagnosis, to identify the N-mix amplification status, looking at other cytogenetics and biological studies. In tumors that are initially deemed unresectable, they may consider at least 2 cycles of induction chemotherapy for the tumor to be reassessed, okay? And usually in accordance with the COG guideline, which is they don't tend to delay surgery beyond 4 cycles of chemotherapy. We follow the CCLG guidelines, so we're more in keeping with the European approach, okay? And the approach is based on risk stratification, okay? So as a result, most of our patients will actually undergo biopsies, okay? In the low or intermediate group, tumors are they fall into 3 broad categories, okay? Whether the tumors are suitable for resection at presentation, whether they're only suitable for biopsy because there's significant image-defined risk factors that makes primary surgery slightly risky, and in the metastatic and the MS tumor groups, okay? So tumors suitable for observation only. Okay, so now this is a very special group of tumors in neuroblastoma. So they are only specific for adrenal masses in infants under 90 days of age at the time of presentation who don't show any evidence of increase in size or increase in urine catecholamine levels. In that case, you can actually observe to see whether these tumors involute on themselves by themselves. But any increase in size would mean that this patient will need surgery. And delayed resection is usually influenced by age and by image-defined risk factors. Okay. So in the high risk group, okay, so because it's high risk and it has a higher mortality, the treatment is slightly more aggressive. Okay, and in accordance with the CCLG guidelines, they would usually undergo induction chemotherapy, followed, and once the tumor has reduced in size, then we would perform surgery. And the goal of surgery, again, is to remove as much of the tumor as possible, if not the whole tumor, without causing damage to any other organs or structures surrounding the tumor. Okay, so sometimes we're able to remove the tumors completely, but sometimes if the tumors are encasing your renal artery or your renal vessels and it may put your kidney at risk, we may have to leave a bit of tumor behind, okay, because it's more important to preserve the structures of the organs, especially the kidneys, okay? And then they undergo myeloablative therapy, and they also, following that, will undergo radiotherapy, and the radiotherapy will be targeted to the original size of the tumor, the area where the original tumor was present, okay? And then they may consider immunotherapy as well. Okay, so as I mentioned earlier, the goal for surgery is always to achieve as complete resection as possible with minimal morbidity. So it's a balance. Okay, that is the end of my presentation. Dr. Low will elaborate further on the management of neuroblastoma. Thank you.
Okay, Assalamualaikum and good morning to all. I hope you all can see my slide presentation. I am Dr. Rozia Shasni, Cik Abdul Aziz from Pathology Department, Medical Officer from Pathology. So I will be presenting the Histopathological Examination for this patient. So we initially receive percutaneous tissue biopsy of this patient, and as you can see in this picture, this strip of tissue infiltrated by neoplastic small round cell arranged in sheets and some in nests. Okay. So in high magnification, these neoplastic cells display round hyperchromatic nuclei, inconspicuous nucleoli, scanty cytoplasm with indistinct cell borders. So based on age, location of the tumor, and the morphological features on histology, which show a small round blue cell tumor, these are our differential diagnosis: lymphoblastic lymphoma, rhabdomyosarcoma, Wilms tumor, Ewing sarcoma, and neuroblastoma. So this is picture for our differential diagnosis. Generally, they look all the same: small in size, round in shape, and they look blue. However, in lymphoblastic lymphoma, the cells are uniform and presence of indented or convoluted nuclei. In Wilms tumor, it shows a triphasic pattern which composed of blastema component, epithelial component, and stroma component. In this area, shows a blastema component, display small round to oval nuclei, scanty cytoplasm, and this is epithelial component, and this is stroma component. In small biopsy, if we only get the blastema component, it is very difficult for us to differentiate Wilms tumor from other small round blue cell tumor. In this picture is an example of rhabdomyosarcoma, and this is example of Ewing sarcoma. So because of morphology, it look the same, and in small biopsy, it's very difficult for us to distinguish which type of small round blue cell tumor. So immunohistochemical study is important to help us differentiate between this small round blue cell tumor. For lymphoblastic lymphoma, they are positive for CD45 or LCA, and also blastic markers TDT and CD34. For rhabdomyosarcoma, it will be positive for desmin, actin, myogenin, and myod1. They are show variably positivity for synap2 and CD56, but usually negative for chromoganin. For Wilms tumor, they are positive for cytokeratin and EMA, WT1, and for blastema component, they are positive for desmin. In Ewing sarcoma, they will show strong and diffuse membranous positivity for CD99 and also FLE1. However, we don't have FLE1 in our center. For neuroblastoma, they will positive for neuroendocrine marker, mainly synaptophysin, and also FOX2B. FOX2B, we also don't have FOX2B in our center. So back to our patient, the tumor cell shows positive for neuroendocrine marker, chromoganin A and synaptophysin. And for CD99, it is inconclusive because it stained the background, and the tumor cell show negative for LCA, so we can exclude the lymphoblastic lymphoma. They're negative for pancytokeratin, EMA, WT1, so this is to exclude the Wilms tumor, and also they're negative for desmin, so can exclude rhabdomyosarcoma. So And then we proceed with fluorescent in situ hybridization, fish analysis for EWSR1 gene. So for this patient, show many nuclei with normal pneumo signals, which show no split signals. So there is no evidence of EWSR1 gene rearrangement. So picture on the left side is the patient sample. We can see there's nuclei show red and green signal, normal red and green signal. They are fused and very close to each other. Okay, this one. On the right picture is the example of EWSR1 gene rearrangement. See, this is a normal signal, red signal and green signal fused together, and this is split signal. The red signal and the green signal is separated. So, however, we still cannot exclude the Ewing sarcoma because the translocation of the EWSR1 on chromosome 22 with FLI1 on chromosome 11 that form EWSR1 FLI fusion gene is account about 85% of the Ewing sarcoma. Another 10% of the Ewing sarcoma shows translocation of the EWSR on chromosome 22 with ERG gene on chromosome 21 that form EWSR-ERG fusion gene. So we did another other fish analysis for Mibg gene. So it shows 100% of total counted cell, which is 100 nuclei that express non-amplified signal. So it is consistent with normal Mibg status. Picture on the left side is our patient. So we can see the red signal is the Mibg gene and the green signal is our control probe. Okay, we can see the 2 red and 2 green. So we count up to 100 cells and we calculate the ratio. So for this patient, ratio is 1, so it's not amplified. We consider it's amplified if ratio more than 2. If you see the picture on the right side, this is an example of Mibg gene amplification. You can see this nucleus, the red one is the Mibg gene, shows a lot of red signal compared to contour signal, green signal. So this is amplified. So, however, we also cannot exclude the neuroblastoma because only 20 to 25% of neuroblastoma cases show Mibg gene amplification. So, based on morphology, immunohistochemistry study, that we already exclude other small round blue cell tumor, and after fish study, so we conclude that percutaneous tissue biopsy for small round is a small round cell tumor. We give differential diagnosis include Ewing and neuroblastoma. So later we received the big specimen, a left retroperitoneal tumor of this patient. So grossly, the tumor is encapsulated, circumscribed tumor measuring 170 mm in largest diameter, weighing almost 1 kilogram. On cut section, the tumor shows solid, fleshy, lobulated grey surface with extensive area of hemorrhage and necrosis, and also presence of gritty sensation upon slicing. So this picture show low magnification of the tumor. So you can see this tumor is encapsulated tumor. You can see here this tumor is surrounded by the fibrous capsule. And this tumor composed of small round cell that arranged in sheets, also some in nests. And here, presence of extensive area of necrosis. So in a higher magnification, the sheets of tumor cell is demarcated by thin fibrovascular stroma septa, and also presence of a background neutrophil here, and also microcalcification here. So in high magnification, again this neoplastic cells display small, round blue cell, hyperchromatic nuclei that exhibit granular chromatin, inconspicuous nucleoli, and scanty cytoplasm. So we also see scattered hemorrhoid rosette. Okay, presence of, it shows a pale neutrophil at the center surrounded by tumor cells. So from our histological examination, you can readily recognizable neutrophil in the background with less than 5% of neuroblastic cells differentiating towards mature neurons. So we proceed with immunohistochemistry. So this tumor shows positive for all neuroendocrine markers, which are synaptophysin, chromogynin, and CD56. So this is for CD99 throughout Ewing sarcoma. This is contour tissue, and this is our staining. Unfortunately, it's inconclusive because it stained the background. So we send to the HKL and we repeat the CD99, and it turned out to be negative. Another marker we proceed is NB84. It shows positive. NB84 is a neuroblastoma marker. It is highly sensitive and positive in more than 95% of cases. The FLE1 is negative. So this FLE1 antibody to the FLE1 are positive in 70 to 90% of an Ewing sarcoma. So mostly reflect the presence of EWSR1 FLE1 fusion protein. FLE1 expression is not generally seen in other tumor, including rhabdomyocyte, mesenchyma chondrocyte, neuroblastoma, and Wilms tumor. However, lymphoblastic lymphoma are routinely FLE1 positive. So other markers, the neoplastic cells are negative for pancytokeratin, LCA, desmin, LBT1, and vimentin. So we proceed with FISH analysis for EWS1 gene. So out of 100 nuclei counted, 88% show normal signals and only 12% show split signal. So it is no evidence of EWS1 gene rearrangement. So our final diagnosis for left rectoperitoneal tumor is neuroblastoma Schwannian stoma poor polydifferentiated. So we refer this case to Prof. Sameh Kahwash, Professor Sameh Kahwash in Ohio State University. So he proceed with POX2B immunostain, which show nuclear positivity. So his interpretation based on H&E findings supported by positivity of the highly specific marker POX2B, findings are consistent with neuroblastoma polydifferentiated. With that, I thank you. I end my presentation.
Zina, shall I share my screen?
Can Doctor try to share your slide? Okay, nampak.
Yeah, good morning, everyone. I'm No Sikai from Pete Sim Ong unit. I'm going to talk about neuroblastoma treatments, non-surgical perspective. In general, I'll talk about the overview of the treatments, and we focus a bit more on these high-risk treatments and a bit on these neuroblastoma in adolescents, which is extremely rare, and any future hope for these high-risk neuroblastoma patients. The treatment in neuroblastoma in general is very important to look at the risk stratifications. In general, historically, it can classify into three risk group. A bit more special compared to other tumors, other than the tumor stage, you look at the age and the molecular or biological profile of the tumor, which is Mibg amplifications, all right? And these two factors will swing your intensity of the treatments. Low-risk patients tend to be a younger age. For infantile neuroblastoma and those less than 18 months old, they are doing pretty well. The majority of them will fall into the low-risk patients. And those older patients, more than 5, they tend to fall into the high-risk group. And this biological profile of tumor, specifically Mibg amplification, is an independent risk stratifications. If those with Mibg amplifications, majority of them, or almost all of them, will fall into the high-risk risk stratification, regardless of their staging of the tumor most of the time. And you can see here the low and intermediate risk, they are doing pretty well. The outcome are almost 80-90% of 5 years overall survival, but not so much on the high risk group, where the outcome are still poor and dismal, which I will elaborate a bit more on that. For low risk management, a lot of time you may not need to do anything if the patients are asymptomatic. It means you just follow up the patients, especially for infantile neuroblasts, they can regress spontaneously. And a number of cases also, you just need to resect it surgically and do nothing, or like a bit of a low dose chemo, and they are doing pretty well. And intermediate risk, the backbones are mainly chemotherapy and surgery. It can be a neoadjuvant or adjuvant or both. So the backbone is still chemotherapy and surgery for intermediate risk, and some may need radiotherapies for these intermediate risk. And for high risk, the treatments can be a bit complicated, which I will try to elaborate a bit more after this. And histology classifications is important, but in certain cases, we have a group called unfavorable histology, where undifferentiated neuroblastoma tend to carry a poorer prognosis, and some of them may fall into the high-risk treatment, as I'm showing in the chart here. So I guess you all have heard about the staging. These NRG staging are mainly a pre-operative staging. It means that you have not operated on this patient and you stage it, mainly to decide on whether are we going for upfront surgery or are we going to give further chemotherapy, neoadjuvant chemo before the surgery. For our patients here, these adolescents, and all these staging are mainly based on a large cohort of young patients, as we know that more than about 90% of cases present less than 5 years of age. So all these stagings and all these treatment guidelines are mainly based on the young child who is less than 5 years of age, and we try to extrapolate for older age group. So for our patients, you can see there's no image-defined risk. It's not encasing any vessels, not going into the paraspinal regions, but it's a huge tumor with a risk of surgical-related mobility. So these patients at diagnosis is L1 disease. It means a localized disease. Preferably can be resected out front. Regional lymph node involvement do not upgrade the treatments or do not upstage the patients if the patient has regional nodes positive. All right. So for these patients, L1 disease, likely regional nodes met on the imagings, and this patient successfully underwent surgery without any complications and resected primary tumor completely. All right. And HPE shows undifferentiated neuroblastoma. It's unfavorable histopathology features, but again, these molecular profiling shows that Mibgs are negative, which is some sort of expected. I will explain a bit more because Mibg positive tend more common for those less than 5 years of age. So in these patients, it's just by look on the stagings and risk specifications, can we say that this is just L1 tumors with Mibg negative and resected completely? I guess shall we be happy and just resect it and watch and see? So I think there's a major dilemma here. before the INRG stagings, we have this post-operative staging, which used in early days before 2010. We call it INSS, is the International Neuroblastoma Stagings, where they look at the post-operative stagings. A lot of experts will suggest to combine both INRG and INSS stagings for you to decide on your treatment plan rather than just pre-operative. So for these patients, they fall into the stage 2B, where you have a resected tumor, but lymph nodes are involved. So they fall into a 2B. Again, there's a concern that these more than 10 adolescents with unfavorable histology, which is undifferentiated neuroblastoma. Is it justifiable for high-risk treatments or not? Like we can see here, if it's L2, more than 5, undifferentiated negative, is it justifiable for high-risk treatment? So there was a dilemma, but we agree that this patient should receive adjuvant chemotherapy. However, sadly, that I think parents opted for wait and see. So within 3 months, imaging shows this child had progressive disease with regional nodes enlargement, and it become metastatic and enlarged. And also there's a bone metastatic lesions. As a part of staging, bone marrow was performed, but no bone marrow involvement. So again, this is considered a metastatic lesion. So it was treated as a high risk at this point of time. So in general, the high-risk neuroblastoma is a very intensive treatment. Just try to show the basic 4 phases here. Your induction, consolidation, and maintenance, taking care of the minimal residual disease. So for inductions, chemotherapy and surgery, resections of primary tumor, which is quite a standard of care for all the solid tumors, and consolidate with radiation therapy, which is also it's quite a part and parcel of the oncology treatments. However, in neuroblastoma high-risk patients, you advise to consolidate with a high-dose chemo with a stem cell rescue. In short, you're doing autologous stem cell transplant as a consolidation treatment for high-risk neuroblastoma. And maintenance to take care of a residual tumor, you add in immunotherapy and cisretinoic acids. Try to show the evidence. This chart is mainly shows a paper published in New England Journal in 1999, where the autologous stem cell and cisretinoic acid have been incorporated as a part of the treatments. The light blue, which is the lower chart, it shows that chemotherapy, conventional chemotherapy itself with the surgery, the outcome are extremely poor. You're going to have a 20% of event-free survival or even overall survival in this group of patients. But if you add in autologous and cisretinoic acid as a maintenance, you improve significantly the event-free survival to almost like, I think 46% of the overall event-free survival. And later, 10 years later, in 2010, the standard of care using autologous and cisretinoid with the conventional surgery and radiations, its outcome is still poor, less than 50%. So with adding in the immunotherapy, it seems like it will achieve the event-free and overall survival much higher to more than 50%. But again, it's still considered a poor outcome. In terms of immunotherapy, what are we talking about? Mainly monoclonal antibodies against GD2. GD2 is antigen that expressed in abundance in neuroblastoma cell. Of course, it also expressed in some of the peripheral nerve cell in a very restricted number. So it shows that by giving this monoclonal anti-GD2, you're going to improve the overall event-free and overall survival to more than 50%. So as this adds to the summary of that simple diagram, just to try to highlight that it's very complicated kind of or very intensive kind of treatments, that you have multiple combinations of chemo as inductions, then you give autologous surgeries as a consolidate, then you take care of the minimal residual disease with the immuno and the cisretinoic acid. How about in these patients? Neuroblastoma in adolescents, we know that extremely rare. We're talking about less than 5% of the cohort among these neuroblastoma. And historically, we know that they have a poor outcome. They tend to do poorly in long term, regardless of the stage and the site of the lesions. And most of them, if you need chemotherapy, it tends to be a chemo resistant. And the clinical costs are more indolent. They can survive longer, but for stage 4 disease, you have much lower kind of overall and event-free survival, which is extremely poor, and it's a dismal outcome for stage 4. And now with the molecular profiling on top of these historical morphology classifications, we know that these adolescent neuroblastoma, they have a different biological profile compared to patients less than 5, which is a majority of the patients. They rarely have emic amplifications, but a number of them, they have ALK mutations or anthrax mutations, which can occur up to 40% of the cases. So it seems to be, they may fall into the different biological profile, and that may explain the different clinical features or clinical outcome of this group of patients compared to less than 5 years of age. So for our patients, sadly, I didn't put it here, is after 4 cycles, when they repeat the imaging, there's no changes in the localized lymph nodes, but there's an increasing on the bone lesions. So on top of that, so-called intensive treatments, any other things that we can do to improve the outcome of these high-risk neuroblastoma or some of the or majority of these adolescent patients. There's a few clinical trials looking at the treatments adding on the standard of care. A few major neuroblastoma group look at the tendon transplant. What means that tendon transplant is whether you do a single transplant autologous, as I stated before, you do 2 autologous transplants sequentially within 2 months in this group patients. The early data since shows that improved the overall survival of increasing about 10%, but not much of difference in terms of overall survival, improve in event-free, but not so much of overall survival. However, in India, comment is this is early data and the number of patients are small, so it is not robust enough to shows a difference in the not power enough to show a difference in overall survival. So can be a tendon transplant adding on this intensive make a difference or not? Or there's a phase 2 trial looking at MIBG treatments for those MIBG avid patients. It's something like iodine treatment for this thyroid CA. As those MIBG avid patients, they may have uptake of this MIBG radionucleus, so we give a high dose MIBG radionucleus contrast as part of treatment. And ALK inhibitor have been treatments, FDA approved treatment for majority of adult cancer with ALK mutation. So they try to incorporate this ALK inhibitor also among those patients with ALK amplifications or mutations. However, we have yet to see what is the benefit adding on these treatments on top of the standard of care for those high-risk patients. Is there any hope on these high-risk patients who is chemo resistant? Now the molecular era, you have been shift the paradigm of classification or reclassifications of the tumor compared to just purely historical histology classifications. So the next generation sequencing have analyzed this high-risk neuroblastoma, and they found that other than emic-driven, you have a few other molecular or genetic marker that you may need to take into consideration with. And in 2019, I think this International Neuroblastoma Pathology Committee, they are trying to propose a new subgroup on this unfavorable histology neuroblastoma. So other than emic, they try to propose other 2 groups, which is a TRT subgroup. It means that those patients with a telomerase substrate protein overexpressions, they've been found that they have a dismal outcome. And also ALT subgroup, which they have anthrax loss, that again, they do show a very dismal outcome in this group. Or now means that they don't have MIG, they don't have a TERT, and they don't have a ALT. So these subgroups are mainly on the proposed for management purpose. So this MIG, TERT, and ALT subgroup, they are non-responder to the current high-risk standard care. So compared to those without these expressions. So for this group, are we talking about possible potential targeted? I guess all these targeted treatment are still mainly at the preclinical. As you can look at MIG subgroup, you may talk about small molecular inhibitor, TARG, some telomerase inhibitor. There's a commercial name there, Immotelstat, and also this ALT group, and talk about ALT inhibitor or the pathway that you involve this ATR kinase inhibitor. Again, all these things are hopefully looking for future that which will improve outcome in this group. I would say especially those high risk and especially those adolescents that they do not behave as other less than 5 years of age patients. Yeah, thank you.
Okay, thank you, Dr. Loh. And thank you to all the presenters for a very good presentation. The reasons why we discuss these patients is basically there are a lot of dilemma in terms of diagnosing the patient because of the patient fall out of the age range of neuroblastoma. And there is also a management dilemma and also diagnostic dilemma. So as you can see, it's not as normal, straightforward neuroblastoma that we usually face with. So if you guys have any question, we can accept the question from all of you.
Boleh tak saya, sementara kita tunggu soalan, boleh tak saya pancarkan Kahoot sebab 9:30 ada JKM.
Yeah, Prof Azmi already needed the thing for their conferences. I think should be okay, Buhari.
Baik, Prof.
Okay, thank you.
Okay, Kahoot quiz ni untuk medical student. So seperti biasalah gunakan nombor matrix . Tahniah kepada semua pemenang Kahoot. Kita akan ambil kira ini untuk anugerah CPC pada tahun depan. Untuk makluman, pada tahun ini dah ada pemenangnya. So nanti akan diberi hadiah pada majlis anugerah sanjungan kencana pada bulan 7. So currently ni yang you all lihat sekarang ni adalah untuk anugerah pada tahun depan. Okay, thanks. Sekarang saya akan pancarkan juga CPC PUAN punya barcode. Okay, barcode ini untuk doktor sahaja. Barcode ini untuk doktor sahaja menggunakan MMA apps. Untuk macam latihan, saya akan share sekali lagi. Saya akan sharekan link di ruangan komen.
Recording stopped.
Nuhari, I think there's no question.